Hi, Michele.
Hi.
How are you?
Fine, you?
Yeah, I'm fine too.
Bom, gente, vamos iniciar o nosso meeting. Primeiramente, eu quero agradecer a presença de todos os doutores que estão presentes no meeting. É um prazer tê-los aqui. Quero agradecer primeiramente em nome da Mectron, que é a nossa parceira da Peso Cirurgia aqui no Brasil. É uma informação interessante. Esse é o primeiro web meeting que a Mectron está fazendo no mundo, tá? A primeira vez, o primeiro evento, a primeira vez, e nós fomos escolhidos aí, fortunadamente, com essa ferramenta para fazer esse treinamento para nós pela primeira vez. Então, temos o privilégio de iniciar esse projeto com a Mectron. Quero agradecer, em nome da DENU, também a presença de todos, meu nome, em nome de todos os representantes que estão presentes também, e do Gabriel, se o Gabriel quiser dar um oi. E quero apresentar, junto também na live está o Renato Di Martino, que muitos de vocês já conhecem. Ele é o diretor global de vendas da Mectron, né, para todo mundo, e o Michele, que é o nosso gerente para América Latina. So, Michele, now
Hi everybody.
Eu só queria pedir, reforçar, todos receberam o e-mail. Vou pedir para que todo mundo desligue o áudio, por favor, porque para não ficar nenhuma interferência do áudio, às vezes faz algum barulho, alguma coisa. De preferência, desligar a câmera, por favor. Se todo mundo ficar com a câmera ligada, o vídeo vai ficar muito pesado e pode dar alguma interferência para vocês assistirem a aula. Então, peço para que todos desliguem a câmera e o áudio, para que a gente possa ter a melhor eficiência aí do aplicativo durante a transmissão. As perguntas poderão ser feitas, tá, ao final da apresentação do Dr. Fabrício, tá? Todas as perguntas, por favor, coloquem no chat. Por favor, escrevam o seu nome completo e a pergunta que vocês querem fazer. Nós vamos seguir a sequência das perguntas em filas. O primeiro que perguntou vai ter a primeira resposta e assim por diante, tá bom? Eu vou ler a pergunta, o nome do profissional que fez a pergunta e a pergunta, ou se eu posso falar o nome, sei lá, Dr. Rodrigo, aí o Dr. Rodrigo pode fazer a pergunta, ele pode ligar o áudio e o vídeo para fazer a pergunta para o doutor diretamente, se quiser. Tá ok? Eu vou estar à disposição para fazer essa moderação junto com o Michele. So, Michele, I think that
Um segundo, Thiago, deixa eu dar uma boa tarde para todo mundo. Agradecer a participação de todos, né? Com certeza é um momento que a gente nunca esperou passar, mas certamente isso espero que em um curto período de tempo acabe e a gente volte à nossa rotina. E obrigado aí da participação e do dispor desse tempo de vocês todos, né, que são um grupo extremamente selecionado e diferenciado perante o mercado. E é aquilo, nunca tive tanta saudade de receber uma ligação que o instrumentador está atrasado ou que o motor quebrou. Até isso está fazendo falta. Então, vamos ter paciência, todo mundo, se cuidar e daqui a pouco volta na normalidade aí. Obrigado à participação de todos. And Michele, now you can start the meeting.
Thank you.
And thank you, Mectron. Thank you and Renato for all the support you are giving for us. And let's start.
Thank you.
Our pleasure.
Thank you. Good morning, first of all, and I want to thank you, everyone, and I hope you are all well. Thank you also, Deno. Thank you, Tiago. Thank you, Gabriel. And of course, thank you to Dr. Fabrizio Spallaccia. Let me introduce him. Dr. Spallaccia is the Chief of Maxillofacial Department in Terni. He's ordinary member of the Italian Society of Maxillofacial Surgery. ordinary member of the European Association of Craniomaxillofacial Surgery, and members of the European Society of TMJ Surgery. From 1998, he works in maxillofacial surgery department with particular practice on TMJ surgery, orthognathic surgery, oral and pre-prostatic surgery. Since now, he has done more than 2,000 surgical procedures as a first operator. He's going to present you the lecture, Piezosurgery in Orthognathic Surgeries, Tips and Tricks. So he's going to present you his experience with the piezo, showing the advantages of piezo in the orthognathic surgery and discovering the best and the proper use. So, Dr. Spallascia, please, if you want, you can start. Thank you, everybody.
Okay. Welcome to everybody. And unfortunately, I never been in Brazil till now. But I am very grateful to your country for the cares, obviously, and for these two guys that was born not far from São Paulo, I think. But these two guys led our soccer team, AS Roma, to one of the 3 Italian championship in the 80s and to the final of the Champion Cup in the 83. But we have lost with Liverpool, man, it's another story. So I live in Rome, of course, but my job is in this little town that is 100 kilometers away from Rome, in the navel of the Italy. The name is Terni, and a special thanks to all of you. Because you, like us, are suffering the serious consequence of this infamous virus. I hope to carry you 1 hour of evasion talking about piezosurgery, efficiency and quickness. And of course, we all know what our father or maybe the grandfather used for osteotomies. First, jiggy saw in the past, and chisels. In the recent past, the rotating drill, the rotating birds, and the saw. But now, in this topic, I'm going to demonstrate you that piezosurgery is now the gold standard for maxillofacial osteotomies. So the piezo technology started definitely in 1999 with Tommaso Vercellotti, that is a dentistry from Genoa. With the Mectron, he realized the first piezosurgery machine for the dental use. Going up to a few years ago, when the Mectron realized the piezosurgery plus, to other machines that are dedicated to the operatory room works, not for dental office. This machine has a double tools. One standard and one more powerful that is better indicated for that osteotomies, like genioplasty or like resection of the bone for oncological problems. Going to PubMed in 2014, I have found that the 242 articles about piezosurgery topic, but a recent review, I have found the double number of the articles on piezosurgery. Now are published 420 articles on piezosurgery. The 43% in dentistry and oral surgery, and the 29% in maxillofacial surgery. So the 3/4 of the total are still in oral maxillofacial surgery. The 20% of the maxillo articles are in orthognathic surgery. So we have 23 articles, not so not so a big number, on orthognathic surgery. The parameters studied were the inferior alveolar nerve disturbance, the intraoperative blood loss, and the osteotomy time. The nerve disturbance for the 65% of the authors are lower in piezo patient. For the 17% are the same, and the same percentage are not evaluated. Only 26% of the authors affirmed that the intraoperatory blood loss is lower in piezo technique, and even only the 4% of the article wrote that the surgical time of osteotomy with piezo is longer than the other device. So this was at the beginning a big problem that the surgeons declares for the piezo surgery, because it's too slow. But until now, the 4% of the authors write that the time of the osteotomy is longer than the other tools. Maxillofacial surgery is an orthopedic surgery. We all know, everyone knows this. And most of the procedures are done on facial bones. So the piezo surgery has almost completely replaced the drill in our department. And the drilling inserts allows the surgeon to eliminate the drill by the surgical field, whereas the Mectron made the inserts for each kind of fixation screws. But topics now is on orthognathic surgery, so move on. These two movies shown that not only the operatory time is quite the same, but also that you can see how the piezosteotomy in the LEFOR1 procedure is more thin and precise. You can guide the piezo insert like a pen, and the 10mm length of the operative portion can done most of the traditional chisel job, like the osteotomy of the medial and the posterior maxillary walls. I reserve at the chisel, the curved one, only the disjunction of the pterygoid bone from the maxilla. LEFOR1 osteotomy can be performed with the saw too, but in my opinion, it's not easy to drive like the piezo, especially for the beginners, for the young surgeons, because it's easy that the saw go in a wrong way. It's not easy to drive like piezo. Piezo is a pen. When it's necessary to remove posterior bone in order to elevate the maxilla, the piezo helps the surgeon to dance in the bone around the posterior palatine artery and the soft tissues back the posterior maxillary wall. So you can dance with the Omphageser retractor. You can move away the bone. Here you can see the artery. So you can make another osteotomy along the bone to remove safely the posterior wall of the maxilla. Certainly you can do it also with diamond bars or osteotomy bars, but it's more dangerous. And at the end of the game, you have to remove just the bone around the artery. You can see here the artery. This is the bone around. In my experience, it's better for the last step to remove the bone, like we see now, to remove the bone not with the burr, but with a osteotomy plier. This is the bone, this is the suction cannula, this is the down fracture, and the last step is this is the osteotomy plier. you can switch the bone gently, so you can see gently, so you can isolate the artery, and with an Nova-Gazer retractor you can remove easily the bone around in order to impact the maxilla up. For the safety of the inferior velar nerve, we have to consider that the nerve usually become external, lateral going forward, and knowing the classical osteotomy described by the authors on the mandibola, the more our osteotomy is anterior, the more is the risk of the nerve damage. The safety osteotomy are this one. This is the osteotomy that I practice in the third class. Maybe in the second class, I go a little bit forward, anterior. I usually perform the sagittal split osteotomy all with one insert. That one is MT110 for the standard tool, or MT410 for the Piezo Plus. The Piezo Plus, I think that is more powerful, around 30% respect the standard one. Someone likes the Uniware insert, that is this one for the sagittal osteotomy. I don't like so much because the working part is too short for me. We all know that the particular shape of the mandibola in the inner side, the bone is thick around the spic spine, and it's not necessary to make the osteotomy until the border of the lower border of the mandible, because the fracture usually comes here in this zone. So you can introduce your blade, the blade of the piezo, inside the two layers here, and goes around the nerve until the middle of the mandible. And as we can see in the next slide, you can insert all the working part of the insert inside the two layer. In the external part, the trick is the osteotomy of the lower board, and do it with the saw. The saw would result in an enlargement of the soft tissue approach caused by the straight length of the tools, and otherwise it's necessary to well protect the lower soft tissues from the saw, from its pistoning movement. We all know that the possible damage of the nerve could be done also by the position of the screws, especially for the bicortical screws, and also by the lengthening of the mandible that could be stretched to match the nerve. Okay, this is the main slide of my presentation. I have to well understand how the piezo, you know better than me, but do you understand, for me, why the piezo is the gold standard for sagittal split osteotomy? I repeat that I used only this insert with this particular shape. Because this particular shape allows the surgeon to go between the two cortical bone, much more deep than you can do with the drill or the saw. You can see that this is the drill. You can penetrate the two cortical layers, the third cortical bone, just few millimeters, because the shape of the drill do not allows to go deeply than this. The particular shape, the angulated shape of this insert, permit you to go inside the bone much more than the drill, and much more of the saw, because the saw is straight, is not angulated like the insert of piezo surgery. And in the external osteotomy is the same, because the rotating drill can go inside the two bone just few millimeters, because then there is the round part of the tool. With the piezo, you can go inside the two bone as much as possible, because the secret of a good open of a sagittal split, you don't know well than me, is this. It's to interrupt the inferior border of the mandible. When I perform the external osteotomy, first I stay up in a perpendicular way with the bone in order to interrupt the cortical layer. We all know that in the middle, around the middle of the mandible, run the nerve. So we have to go deeply in the up part and the down part, and be careful in the middle part. So with the piezo can penetrate all the instruments inside the two layer, as we can see here. And then you can see that I change my angulation, because after the interruption of the cortical bone, I go inside the two layer and put all the working part of the piezo inside the two layer. This is very important, because you make an osteotomy of completely of the mandible. You can divide all the two bone, all the two layer. And the real important thing is this. So if you done this osteotomy so well, it's not necessary to use the chisel, because we don't know that the chisel is very dangerous, especially in the external part, for the health of the nerve, because if you don't put the chisel very well in a very correct way, it's possible again with the hammer and the chisel inside the bone, you can cut directly the nerve. If you perform this osteotomy well, the mandible opens by itself. It's not necessary the chisel with the hammer, but is necessary or only a meniscus mender like this to open the mandible. So you can evidence the nerve if is entrapping on the bone. You can isolate with an Obweiser, and so in this way you have to make all the osteotomy. So you can detach the internal pterygoid muscle. The new MT913 insert is a revolutionary one, because besides having a more open angle that allows the surgeon during a sagittal split osteotomy external procedures, it cuts all over his surface, This is the MT4, the MT1 cut only in the tip, and in the MT913 all around. So you can do the osteotomy in reverse mode, as you can see in the movie. This is a procedure very friendly to the old surgeon that makes this osteotomy with the rotating drill. So they put the drill at the bottom of the osteotomy, and they came up. So it's possible to do it with this insert. This insert is a preferred choice also for sagittal palatal osteotomy, because the more open angle that you can see, respect the other insert, and the larger working tips allows the surgeon to do his job, also without the maxillary down fracture. You can see here the down fracture, but often is requested we call SARP, an osteotomy of the palate without down fracture. So this is possible with this insert, because as you can see with the MT110, you can cut, osteotomize the nasal spine in order to have a perfect centered here osteotomy through the roots of the teeth, and then makes the osteotomy of the alveolar bone with the MT1 or MT4. But for the palatal osteotomy, it's better to use this insert, the MT913. Why? Because with this insert, you put insert in the maxilla and the palate, and with the finger you touch the palate, the hard and soft is not necessary, but the hard palate, in order to feel that the insert don't come over the bone and don't interrupt the fibromucosa. But if you feel the insert, you can dance on the bone. You can do a perfect osteotomy. That is very difficult with this insert because it's too much angulate. Okay, in this slide you can see how piezosurgery works in segmentary osteotomy of the face. MT110 allows to cut the bone in genioplasty. I suggest you to use this in genioplasty because genioplasty is an hard bone, and MT110 is a little bit slower for this, but it's the same. You can do it also with this insert. But the advantage of the use of piezosurgery is you can do it in a blind procedure. It's not necessary to distract the lip, to separate the lip and the soft tissue from the osteotomy line, because if you don't push too much on the tip of the insert, you can not damage the soft tissue. This the fact that you do not retract too much the soft tissues is important, because you do not stretch the Mentonian nerve, the end of the alveolar nerve. And because usually in the genioplasty, the patient after have a palsy of the sensibility of the nerve. So with this insert, you can, it's not necessary to divaricate so much the soft tissue, so you don't stretch the nerve. And on the right side, you can see a Wasmund osteotomy. This is a maxillary segmentary osteotomy, and with the insert is very thick. You can go inside the cortical bone, and you can do it without any damage with for the roots, because the tip of the insert is a blade, it's very thin, so you can do directly without damage of the root. Also in corticotomy procedure, the particular thinness of the insert allows to perform the cortical layer and the external part of the medullary bone without high risk for the roots. The same thing, the same procedure. You can go inside the cortical, and you can go in the medullary too, if you want. But your roots are saved. This is not easy with the drill. The drill, because the drill makes a larger than this osteotomy, and with the saw, because this saw is not easy to guide or to drive. Okay, the technical notes are ended. Now I want to show you 3 clinical cases, all made with piezo, but done in different period with an ascending scale of technology. These are not my best cases, but are important to explain you how the piezo technique helps us during the evolution of technology. First case was a case called the ERA 1.0, in which we used standard cephalometry, piezo of course, and plaster model studied on gnatological articulator and stock titanium plates. This is a clinical case of a 39-year-old patient who had suffered a trauma during her birth. Maybe the right condyle was broken, but no one had diagnosed it. Her face had developed in a very asymmetrical way. As she was living in the south of Italy, she contacted us via web in order to ask if it was possible to correct his deformation. You can see here how the mandible is changed. The condylar, the left condylar is have done a growing, exaggerate of all the ramus of the mandible, in order to avoid, in order to help the patient to articulate the mandible. So we have scheduled 2 surgical steps. The first one did our best to recenter the face with condylar remodeling and a discoplasty, because the condylar surface was very regular, and I was worried that after the maxillar mandibular repositioning, the suffering condyle could resorb itself, modifying the posterior vertical height, in accordance with the Larry Walford philosophy. This is a design which are explained how the disc is repositioning on the condylar remodeling and fixed with a resorbable screw, a resorbable pin. The second, excuse me. The second step is a Lefort-1 osteotomy to rotate the maxilla, a right intraoral vertical osteotomy, and a left sagittal split osteotomy. Why intravertical right osteotomy? Because the sliding of the 2 bones makes a new condyle, because the posterior side goes up and the mandible goes down. So we have a new condyle. I did it all with one insert. This is the classic one, and this one for the right vertical ramus osteotomy. After a few months, we have scheduled the second surgical step with the chin repositioning and the right mandibular angular remodeling. As we have said just before, for a vertical ramus osteotomy and for the remodeling of the angle of the mandible, we have used this piezo surgery insert that have the saw angulated respect to the insert in order to do it in a very comfortable way, to resect this part in a very comfortable way. This is the final radiography of the patient with all the plates that we have used. And this is the final result, the comparison for before pictures and after pictures. You can see how the face is recentered. The occlusal bite plane is good, is not canting, and also if the face have the stigma, the characteristic or the preserve the memory of the past asymmetry, now he has a new symmetry, a new center of the face, a new face. The case 2.0 is a case of a patient planned with a specific software and realized with 2 CAD/CAM splints. A young patient who had a psychological problem for her face, not so ugly, but she didn't like his gummy smile, the little chin, and for the shortening of the lower third of the face. We used a tricky cone-beam study that is, you know very well, is like a CT, but the radiation is very low. And the elaboration with the Dolphin software planned an asymmetrical inspection of the maxilla. This is the planning with this software. The inspection of the mandible, asymmetric inspection, the counterclockwise rotation of the third middle and the lower face, and a forward genioplasty. So we had started with a mandibular first procedure, fixed on the maxilla with the help of an intermediate custom splint, a forward genioplasty, and a left for one of a symmetrical vertical inspection guided by a final custom splint. So one intermediate splint for reposition of the of the mandible and another splint for the final occlusion. This is what we usually call it the anteface. That is a counterclockwise rotation of the middle and the lower third, in order to have a vertical and a forward augmentation of the face projection. This is the final result. The patient now is very happy and opened an Instagram profile from which I stole some photo. From this superimposition, you can observe the amount of the third low advancement. The final patient is a 3.0 patient that was made with the cutting eyes and the custom titanium plates. This is the patient. The particular wave shape of the maxilla was caused by the fracture, not well treated by the other colleagues, and the loss of the incisival teeth. This is prosthesis. Open bite and a retrusion of the middle third. This is the cone-beam study, cone-beam CT. The virtual planning elaborated with the software showed how the movement of the maxilla is very articulate. It would have been very difficult to make this because it's a moment in which the two maxilla that it's necessary to divide it have to shift in different way and position it on the mandible. You can see how the saw is not possible to use the saw, because if you put the saw in this little window, you can you could broke the bone inside, because the pistoning movement do not allows the osteotomy. So it's necessary in this case to use the piezo surgery. So you can see now the two movies, 1 and 2, of the position of the plates, you can see here, and the particular movement of the right side of the maxilla. This is the plates that are placed in the bone that we have made before with the cutting guides. The final result with the closure of the open bite and the advancement of the maxilla. You can see the movement that we have done with the maxilla. The slide shows the supporting position of the two cone beam, pre and post. It's visible the large amount here of the advancement of the right maxilla. At the end of the presentation, I can summarize what are the advantages of the piezo surgery, in my opinion. Better quality in cutting, easy guide the osteotomy because it's a pen in your hand. Same bone healing with the drill saw and piezo, for my experience. I am talking from my experience. Reduced blood loss, a perfect irrigation, because with the drill we irrigate the bone with a syringe that are pistoning by the help of myself, and with the piezo we have a pump in the machine that pump the water at the tip of the insert. Reduce the inferior alveolar nerve injury, of course, for me. Lower heat to cut for the irrigation, I've seen, and less damage for the surrounding soft tissues. Yes, but if you push the tip hardly on the soft tissue broken. It's dangerous for the osteotomy of the palate. It's dangerous for the posterior palatine artery in the left one procedure, and it's dangerous also with genioplasty. If you cut like an assassin the bone and push too much, then goes in the soft tissue and you can cut. Also with of course with the sagittal split osteotomy, be careful, because you can cut in the sternosteotomy. If you go very hardly, you can cut the artery, the facial artery. So be careful. For me, there is no lengthening of surgical time. So this, for me, is the standard tool for maxillofacial bone surgery. We have seen that for some authors describes the lengthening of surgical team, but for me, it's only for the beginners, because if you are able to use these tools, there is not a lengthening of the time. Maybe only in the chin osteotomy, in genioplasty. And the cost of osteotomy, yeah, the cost of the equipment, yes. it's a little bit more expensive, but we all know that Mectron is a friendly company, so they go to our needs. In conclusion, the question is, does the piezosurgery make the maxillofacial surgeon work faster or slower? Neither faster nor slower, but easier and safer. So I have finished. Thank you for your attention and your supporting against coronavirus.
Thank you, Dr. Spallaccia. And there is a question from Renato, and
Yes.
the question is dangerous, but less dangerous than the traditional rotating and oscillating tools, correct?
Of course. The risk for me, the real risk is only on the palate, because at the first time, in the first time that I have used this, one time I cut the fibra mucosa of the bone. And it's not good because you have to suture it in a zone that needs a separation of the bone to stretch, so it's not good. In that procedure, it's possible, if you don't go gently, to cut the fibra mucosa. In the rest of the procedure, it's very low risk, very low risk.
Okay. There is a question from Rodrigo Foronda. First of all, great talk, congratulations. Great presentation. In Italy, do you have a kind of kit for orthognathic surgery with the specific tips, for example?
With the specific?
Tips, inserts, I think.
No.
Dr. Foronda, if you want, you can switch on the camera and the microphone.
Okay. Stop share. Here, you can see, okay. And no, there is not a special kit for orthognathic surgery. There is this insert, a large amount of insert that you can use as you want. My personal experience, I do everything with one insert, but other surgeons have skills with the other inserts, and no problem. But the philosophy of the piezosurgery inserts are the angulate shape, and the fact is very thin, so you can do inside the bone. This is the goal. This is the very good thing, the gold of our speech.
Okay.
Okay, it's corrected. Okay, thank you.
Thank you too. And a question from Andre Reynolds. Are there advantages for the recovery of the patients?
Yes, because it's less traumatic for me for the bone. So the patients stay 2 or 3 days in the hospital, and they go away. No problem for the recovery. Yes, of course.
Okay. There is another question from Dr. Pitta. Dr. Pitta, if you want to switch on the camera and the microphone, please. The question is, do you have any studies for the risks of heat of the bone when you cut between rods in the segmental osteotomy?
No, I don't, because I see, because in segmentary osteotomy the risk is the teeth roots. With the other drills, it's very hard to go inside through the teeth roots. With the advantages of the piezo is the blade. You can cut the cortical bone as you want, because you can handle the tools very easily, and you can go exactly through the roots.
Thank you. Great presentation. Congratulations. Wonderful.
Thank you very much.
Hi, Dr. Pitta. Nice to see you.
Nice to see you.
And another question from Renato. Some authors have documented that by using piezo, the patients go home the same day after BCCO, bilateral sagittal split.
Lo so. We all know that there is a colleague of mine that do this procedure in the office in a local anesthesia, but the judge is not very happy if a patient happens something in his home after a procedure, a surgical procedure. So it's possible that the surgeon goes to the prison because the patient goes to his home very early. It's a risk that in our hospital it's not necessary to run. Maybe in private practice you can reduce 2 days the recovery.
Yeah, this comes from our UK surgeon that he says, I do this all the time. My patients go home the same day of the operation.
Yes, it's a
Raffaini. Depends of the structure, I think.
A Mirko
hospital.
Raffaini friends.
Depends what?
It's a Mirko Raffaini friend.
Okay. Okay. Any questions from the Dr. Toledo, Thais? If you wanna switch on the camera and the microphone, and thank you for the presentation. What about the drill bits? What's your experience? The drills, inserts,
the whole, yes. Allora, the insert for the screws are good, but you have to use only one time because all the inserts are disposable. And if you use the insert for the drill more time and other times that one, it's possible that the tip curved. If the tip curved, enlarge the bone hole, and so it's impossible to put the screw because the anterior maxillary bone is very thin. Be careful. So if you use the insert disposable, okay, but don't put it in your pocket.
The idea is that the insert is single use, so there is not this risk.
Yes, and then there is another thing. If you are able to use the bicortical screws, and so use the transbuccal system, there is not an insert so long for arrive in the mandibula. So you have to use the driver of the screws.
Okay. Other question? I think for another one. Okay. Thank you from the Dr. Thais Toledo. And I think no more question. No. Tiago, do you wanna add something?
Tiago, you have a very good surname. Is the same surname of our manager, Fonseca, manager of Rome.
Obviously, Fabrizio is a very
Ciao, Dr. Passeri.
He's a supporter of Rome.
Rome and Brazil are very linked with many players.
Ciao Michele.
How are you?
Molto bene. Come stai?
Molto bene, piacere di rivederti.
Mi piacere. Devo ritornare per vedere il Palmera.
Sì. Thank you to see you.
Grazie.
And the question from Tiago, do you use the drill tips on the trauma cases?
No, trauma cases is not necessary to perform osteotomies. It's only necessary to reconstruct the face of the patient and to put the drills. So it's not necessary the piezo. But in orthodontic surgery and all the other surgery on the bone, I take the drill and put out the window through the window. I use only piezo surgery because it's now must be the gold standard for this surgery.
Dr. Fabrizio, my question is, if you use the drill tips, is it possible to use the drill tips to fix the screws during the trauma case, for example, to switch the
Yes.
drill,
Yes.
just to use the...
Yes, of course, but you have to put the piezo surgery only for do the piezo the screws, the whole of the screw for the screws.
Yeah.
So it's
Yes.
not so good use of the piezo, but it's possible, of course. No problem. Yes.
Okay.
That's big.
Thank you.
I think you have to think that also the hospital where you work, if you have a problem with the hospital to buy tips
The tip.
or not, that is the problem.
Okay.
Beginning, yes, but now the drill are disposable too. Now, if you buy if you have a striker drill, you have to buy the drill of this one, the birds of the striker. So that's are disposable too. I have the same price of the piezo. But sure, you can use the rotating birds much more times than piezo surgery, because the piezo surgery the first time is a perfect cut. Then the little teeth on the tip of the saw come dire, si rovinano. Doesn't work very well because became flat. So it's better to use the piezo surgery insert just one time.
Okay. This is our normal recommendation.
So, yes.
Single
They
disc.
pay
Yeah.
me for
There is a question from Dr. Miranda. Good morning, Dr. Miranda. If you want to switch on the camera and microphone, and thank you for question. Good afternoon, Dr. Fabrizio. Congrats for your presentation, and thank you for taking the time. What do you say to your patient? What's the percentage of the nerve risk in the B sagittal split?
What I say to the patient.
No, which is the risk to the
risk very low for me. Maybe a temporary palsy of the nerve, but sure, it's possible. But the risk of
in the B sagittal split,
see, a definite cut is very low. If you use in a correct way the piezo is the best tools to evitate this inconvenience. Is the best tools for this.
Okay. And Dr. Foronda asked, how long have you been doing orthodontic surgery only with the piezo?
Since 2011. 2011, when I arrived in the intern. No, maybe no, before.
No, more than I think two years or more.
10, 12 years.
Great. And other question? I think no more. Tiago, do you want to add something else?
Let me know what the experience of my colleagues with the piezo now. What experience? What's your experience with the piezo? What are your impression?
Please, if you want someone would like to
Can I
say
talk
something?
something about it?
Yes, please.
For me, the piezo changed the way I do orthodontic surgery. I cannot imagine doing orthodontic surgery today without a piezo. In the patients that mainly, I started with the patients that first I started on maxilla, like segmentations, and then on the back when we need to put the maxilla back on the posterior part of the maxilla, like you showed, wonderful movie, taking all the bone around the artery, cutting the pterygoid plates, it's great. Nowadays, I do basically 95% of my osteotomies with a piezo, because I use a inferior border saw. But what I saw on your surgery today make me know the hint that I can do everything with the piezo, even the inferior border osteotomy. So I'm gonna try. I hope the patients come to my office after Corona to start doing surgery. Hopefully. It was great. It was very educational. The class, you gave me several ideas to do. It's very nice technique. Thank you very much.
Do you have a standard or piezo plus?
I have the I don't know what I have. What I have, Thiago? Because I use the Thiago. I have a plus, I think.
The most part of the surgery we serve the flex
one,
the standard one. Yes.
Okay.
But we can probably now we need to switch for the plus for everybody for sure.
Okay.
Can I talk? I use a lot of the piezo.
Thank you, Dr. Pita.
Thank you very much. Thank you.
Please,
Thank you.
Rhonda, please.
I use a lot of piezo in my surgeries, and these years, I think in January, I did the first with only piezo. So Pita, it's a good idea to do with the basal, the cutting of the base of the mandible with the piezo. It's very feasible and it's good. It was a good experience to do all the surgery with piezo. But not the genioplasty. I don't know if you can talk about the genioplasty, Fabrizio, but for me, didn't work very well.
Do you make the genioplasty with the saw?
Yeah, in the end with the saw, not with the piezo.
Okay.
I use, you know what? I use 100% piezo in genioplasty. I just love it. The bleeding is much less.
Yeah.
When you put the saw, sometimes you cut vessels on the muscle apart. With the piezo, you don't have the risk to do this. It's very safe and very good, but you have to have this tip a little bit longer that he showed. It's perfect.
If you use the piezo plus, you will see that is faster.
Okay, I will try.
You know what? I don't think that is even using the flex. I don't think that is any problem for time for me. We do in a reasonable time. It's nice. It's okay. But if you go faster, it's better.
Yeah, of course. Thiago, you have to work more to switch.
Yes.
I'll put you in trouble. I'll put you in trouble.
Yeah, put in trouble. We need to buy more plus, so it's very expensive. So Renato, please a discount. And Michele, discount.
We like to see Thiago in troubles.
More, we need
Renato
discount.
can count on me. I'm gonna press him.
Thank you.
We press on both sides.
Okay.
So, any more questions? Se alguém quiser perguntar alguma coisa, quiser ligar a câmera, fica à vontade, ou fazer algum comentário, por favor, fiquem à vontade.
What a fantastic sound of your language.
Thank you.
Okay.
Renato, if you want to add something or want to close this webinar, it's a pleasure for us.
Is our first webinar. I think it was a very good one, and I thank you. I thank everybody, Denuo, the surgeons, and of course Fabrizio Spallaccia.
Thank you, dear.
For being with us today. And that's it. Thank you very much. Hope that this coronavirus madness ends soon, so we can do presentation in person, which is much more nice. And maybe we can invite Fabrizio in Brazil So
Would be
Yes.
wonderful. Would be
It's
wonderful.
For the carnival.
this time in his life.
Thank you, Dr. Fabrizio. It was a pleasure. Very, very good presentation. We have more tips to try to give for the other doctors, for the other doctors as well. And obrigado a todos por dispensar o tempo conosco, por atenção. Sei que é um momento difícil para todos querem voltar a trabalhar o quanto antes, mas o importante é a gente estar bem e seguro. Vamos sair dessa, se Deus quiser, todos juntos. Obrigado a todos. Thank you so much, Renato, Michele,
Ciao,
Electron.
arrivederci.
Thank you, Dr. Fabrizio.
Thank
Ciao.
you. Thank you, Tiago. Thank you, Gabriel.
Thank you.
Rodrigo, we wait you in Italy, in Bologna, which is my hometown, when you can come.
Thank you very much.
Yes.
Bye.
Grazie.
Bye-bye.
Bye.
Thank you, Michele.
Everybody.
Thank you for
Thank you,
everybody.
Michele.
Ciao.